case. So I will be presenting a case that presented to us in New York State just a couple months ago to ground the discussion. And I'm really hoping that this can be a discussion with the whole group, because although we're going to be talking about things like communication with parents and ideas of how testing can be quickly done and insurance, people in this audience have a lot of great experience in that as well. So it's not really us teaching you, but rather us all having a discussion about this. So hopefully people will contribute. So this was me sitting in my office on this day. And it was a Tuesday, and I got this alert at 4:30 p.m. It was day of life 8 of the baby of a positive Krabbe disease. And obviously, I usually, if I can, which I almost always can, drop everything to look at the stats that I get with the referral. This referral, by the way, the New York State was concerned about this patient in terms of infantile Krabbe disease. So as we just heard about earlier, which I think is really, really important, there were mechanisms for New York State to contact me directly, which they did right away. And I received direct communication from New York State, besides the referral, just alerting me to this patient and the concerns that they had. So here's the initial stats that we got, and I don't want to focus too much on interpretation of newborn screen because we've already talked a bunch about that. But you can see here that the kind of initial cytosine on dry blood spot that New York State, the value that they had was 15, and then on follow-up testing that was essentially the same, by the way. So that's the value that they had. Now in New York State, we didn't talk that much about this at the last panel, but New York State does DNA sequencing as part of their screening. That's in second tier, right, Joe? That's second tier, as part of the second tier testing, that the DNA sequencing is done. So that's, you could see there that this baby was heterozygous for the 30 kb deletion. And for VUS, that really didn't have a lot of information on it that I could quickly ascertain in terms of reports that it is a benign variant that's been seen. We actually had, at that time, the inheritance pattern, which is very luxurious when trying to interpret these, because this was a sibling of a previous patient who screened positive but ended up being a carrier, which we do get a lot of in New York State. And as part of that workup, this was a few years ago, parentals had been done. So we actually had the inheritance pattern when we were looking at this initial information. So again, don't want to spend too much time on this, but the first question, I guess, is how would we classify this baby based on this information? And anybody want to take a stab at that one? Anybody? And this is what the Newborn Screen Council is for. You get results if you're not sure. So looking at this, this would be somebody who I think most likely will have infantile Krabbe, given the cytosine value. That's the critical piece of information here, is on the dry blood spot that the cytosine value is over 10. And then we also had the genotype, and although it's not a clear slam dunk, meaning 2 known pathogenic variants, the fact that this other variant, which is actually not present in that sibling, by the way, was the fact that this other variant was not very well understood with an elevated cytosine would significantly increase concern about infantile Krabbe. And this would be a patient that we would treat at this point as if they will have infantile Krabbe based on that information. So we talked about this a little bit, so I'm not sure how much we need to go into this, but the question is how to, as we're putting together these newborn screen programs for very, very urgent possible cases, how do these notifications come in on our end? It sounds like the newborn screen labs, many of them have ways of notifying providers. I don't know if it was 100% or not. There's a few people that had brought it up, but ways of directly notifying an individual who has knowledge in the disease. But how is that process happening? Anybody in the audience, I'll go to our panel in a second, but anybody in the audience, either our lab specialists or providers, have any experience with how best to set up this kind of notification system, including on weekends, et cetera? Yeah.
So before we add a new condition to our panel, our follow-up group starts meeting with our medical providers and working out the details of notification, when they want to be notified, what they want to be notified about, and especially on the weekends. So in this situation, with a cytosine of 15 nanomolar, we would all be in a panic. So we would definitely have already called Dr. Kurtzberg, but our follow-up group would be doing that. And also, working with GGC to get the rest of the family involved with whatever has to happen genetically on their side. But we would be moving very fast.
Yeah, absolutely. And it makes sense. The planning is just such a key aspect of this, having all those conversations ahead of time and know where those are going to go. Anybody from clinical centers who can speak to how these referrals come in, like for are people, is this the person who knows how to interpret this on call 24/7? How does coverage work?
Tough question. So I'm Deepa Rajan. I'm from Pittsburgh. So I come from a place that has the legacy that Maria Escolar has established, and we follow a really large number of patients with Krabbe. So I'm not sure how reproducible this is. I can tell you that when I was a neurologist, with the clinical setup that I had, it would be very difficult to pull through everything that is required. But moving forward, the way our center handles it is we have I'm on call 24/7. Anytime there is, this would be on my, I would be called immediately. And not only am I on call 24/7, but our manager who is able to schedule everybody, every other team that needs to be involved. There is one point person in each of those groups, and they're also available 24/7. I think that becomes very crucial to move things apart, very quickly. This kid would be in my clinic the next day.
Yeah, absolutely. So that's it's important to think about. I'm not sure if the lab calls us in the middle of the night per se, less likely, but definitely during the day on the weekends, there needs to be a coverage system for the individuals who are involved. Maybe they go on vacation. I don't know. So that's really, really important. Yeah. Dr. Rajan.
I think this is where patient foundations can be really helpful to empower one group in every, maybe we have a similar setup that can be reproduced in other centers, or at least a handful number of centers. And that, as you know, would need to be supported for a clinician to be available and time set out to just Krabbe. That I think it's very reproducible. It needs to be financially feasible and supported. In my mind, I think the easiest way out would be patient advocacy groups to support that.
But can you repeat? It's hard to hear.
Yeah, can you just summarize real quick, a little closer?
Oh, sorry. So no, I was saying, I think this is reproducible in other centers, and we should definitely think about reproducing it in other centers, but it can only be financially feasible if it is supported by some group, right? Because I think you can have a clinician, a nurse practitioner, a clinic manager that can be in a certain number of centers or in every state, ideally, that has the expertise in the disease and is available, but how do you support their time to build that expertise and then be available. I think that support should come from patients.
And do you mean a national group or by state?
You know, right now we have a few centers that do this, and right now we have a few centers that do this and have the expertise too. But eventually, every state where we have newborn screening would be an ideal future. I don't know. I would ask Dr. Kratzberg what she thinks about it.
Yeah, it's a good segue. So I was going to go to our panel and see what you think about this question, which is about how best to sort of give and receive this information so it's quick and efficient and gets followed up appropriately.
Yeah, so, oops, sorry, mine is loud. I think it's really complicated. And I think right now it's not happening in any sort of standardized way. And I understand every state is different and that makes it even harder. But I think that if each state could centralize, as you just said, the recipient of this information, and if the recipient had enough background to interpret the result, that would be, sort of step one. Then there's many, many other steps with, who then on the medical side gets the information, who talks to the family. I'm assuming you're going to get to that in a bit. But I do think the recipient of this initial information, whether it's someone in the newborn screening lab, because that may work like you're doing in South Carolina, or it may be somebody outside the newborn screening lab, but somebody who understands what steps need to be taken next. What's the tree of who gets notified next? And, what does this mean? I mean, this one, to me, is straightforward. It's like a scene's over 10. You go, right? And so who do you go to? And what do they do next? That's the next step. But I do agree there has to be some centralized interpretation so that there's a clear sort of call tree to go to know who gets the next call.
Yeah, I agree with that. And I think what you said about having the meeting with your providers if you're a new state is really critically important because, a lot of these people who may be receiving referrals may never have had a baby with Krabbe that went for transplant because it was rare before newborn screening. We're only dealing with siblings. They may not be that knowledgeable, so they need to know this is something that's urgent. And at our state, the referrals all go through the pediatrician. There's no direct communication with the consulting center because they believe in the prerogative of the pediatrician to choose where they're going to refer the patient. So they give them a list of places the patient can go. But I think the urgency has to be transmitted because honestly, we spend a lot of time trying to educate pediatricians and their office staff not to call a patient with a positive newborn screen for, Krabbe disease on a Friday night after they got the result, because they're not going to be able to get anybody at the center until Monday morning, and they're agonizing all weekend on the internet, all of that. So, but this is a very different situation. This is an MSUD kind of situation where the baby needs to go Friday night. Jen was just telling me our transplanter was supposed to be here, but she had to stay back because they got a referral last Friday, for infantile Krabbe. And so it's all in the mix right now. So the center has to understand the urgency, and the people at the state level who are conveying the information to the pediatrician, assuming that's the model in your state, needs to give them very specific directions, because we see a lot of times an urgent situation, but the pediatrician decides to repeat it because they didn't really recognize the urgency of it. And their knee-jerk thing is just to repeat every positive newborn screen. So I think those plans and those discussions have to go on from the very beginning. I would suggest to new states, get all your providers together, get one of these guys, Joanne or Joe or somebody, to do a webinar, give them, some education, look at what the logistics are going to be in your state, see how it's going to work out. But I think doing all of that at the front end, will make a huge difference. I've been dealing with newborn screening my whole career, and I've never met a family who didn't say that first phone call was something that is seared in their memory forever. It's devastating. And it's so important, who makes that call. I mean, it shouldn't be the receptionist at the pediatrician's office who calls the family. And believe me, sometimes it is. And says, your baby had a positive newborn screen for XYZ. And the family says, what's that? And she says, honestly, I don't know, but you need to call this consultant's office to get it dealt with. And, then they can't get through, or it takes a while, and it's a horrible situation. So all of those ducks need to be gotten in a row, I think, really before you begin. And if you've already begun and you feel like there's still flaws in the system, then back up and, try to get it together now. I know in Illinois, when we started doing LSD newborn screening, which we did with a block of diseases early on, we had monthly calls among the centers that were receiving referrals, and we talked about issues coming up, and with a complex disease like Krabbe, I think that's a good thing, as you get things going.
Yeah, absolutely. So to summarize that connection, that very kind of strong and purposeful connection between the lab and an individual or group of individuals in a state that has the most experience and ability to interpret the results appropriately and also have the initial conversations appropriately is really, really important in this condition. This last question is an easy one. I can answer it very quickly. So you have these results and maybe your new state recently set up, et cetera. How do you quickly get assistance if needed interpreting results like these? And we've already learned that the Krabbe Disease Newborn Screen Council is a great place to get that assistance. Yes, our meetings are monthly, so you can't wait for a meeting if you're in this situation. But a lot of the members of the council whose contact information is all available through Hunter's Hope, et cetera, if somebody needed it, are very quick. So between Dr. Kurtzberg and Dr. Burton, myself, Dr. Rossini, Dr. Matern, Dr. Ream, there's a whole bunch of people that can follow up very quickly. If I ever send messages out to this group, I feel like I probably get a response within like 23 minutes as a mean from at least some folks. So there's a lot of support, I think, through this council for anybody across the country who needs help with this. All right, so so you see along the top, I now think that this looks like it's likely going to be a case of infantile Krabbe disease. So it's been about a half hour that it took me to go through all that stuff and the records and figure that out. So we were just starting to touch on this. What is the initial communication with family? And in this particular situation, communication is very different than the most common communication that I do in New York State, and I've done this many times, is the communication to a family that looks like a carrier plus or minus enzyme lowering polymorphisms. So we get a lot of those cases, and the communication is very, very different. So any comments from the group about things your strategies that you consider when initiating a conversation, either about a case that looks like it's going to be infantile disease versus those that look like perhaps it's going to be an unaffected individual? Because as Dr. Burton mentioned a moment ago, that initial conversation is very important.
So I'm one of the pediatric transplant physicians at Nationwide Children's Hospital at HEMA. And usually how I get to know is the genetics team talks to the family up front. And at 5 p.m. on Tuesday, I don't like to have conversations over the phone with the family, which can be very confusing, overwhelming, and Google searching. So what we would have done is brought the family in next day morning and met as a team, which would include the neurologist, myself, and the genetics team. So we would approach the family together and actually talk to them in person. But usually what has happened in the last 3 patients is the genetics team has approached the family and said, there's this abnormal screen. I think we need to talk about this more in detail. this could be, Krabbe, infantile Krabbe in our cases, and we would like you to meet with the rest of the team to go over this. We kind of give them a hint that there's a possible admission going to take place because this is so urgent. We cannot do everything outpatient, so we try to admit the baby immediately. It's very overwhelming for the family if you think about it from the mother's point of view. She's just given birth. We have postpartum issues, and here we are telling baby has a problem and trying to fix it. And so you have to. So we've had instances where the family paused and said, "We just need to process this, and we'll come back." So we have given that 1 day just to process and come back as well. But it's just very overwhelming, and I can see it from a family standpoint. Here we are like a flock of providers sitting in front of you and saying all these complex topics and jargon and trying to make them understand. So that's what has worked for us. In one situation, we had trouble getting to the family because of social issues, and we could get the family only on day 11, I think 11 or 12. Although we knew about the results earlier, but we just couldn't get hold of them. But most of the times we have been, but we try to have conversations in person, especially from a transplant perspective. I don't try to say anything with the phone. Say, can you come and we can discuss?
Yeah, it's a great point. So an important thing that you mentioned there is that the majority of the conversation needs to happen in person as quickly as possible. The family has to be called at some point because they need to be told to come in. But trying to get people in as quickly as possible, hopefully next morning, would be the ideal. So that way you can have the harder part of the conversation in person. I think that for a patient with a likely infantile disease, it's going to be a devastating conversation. And there's really no way to avoid that. Although in the appropriate circumstances, there is hope. So I'll just plug that for Hunter's Hope. But it is a devastating conversation. And there's just, and really we need to just get them in as soon as possible. So that way we can give them all the information. Dr. Reed?
Because of Ohio's unique situation, not having cytosine and having so many high false positives, a lot of times the families already have had significant contact with genetics by the time Hema and I see them. And we have had 3, infantile Krabbe cases identified by newborn screening that we've transplanted. This one family she mentioned was day 47. I think the rest were just under 30 or right around 30. But so Ohio's newborn screening lab utilizes the kind of urgent metabolics network that we already have in place for the metabolic conditions picked up by newborn screening. So genetics, has someone on call, they have genetic counselors on call. So those calls will go to pediatrician, and for something like this would go to a regional genetic center geneticist. A lot of times those, once contact with the family is made either by the PCP or PCP asks the genetics department to handle it. A lot of times that initial contact for us is through a genetic counselor over the phone, which can be, at 5 o'clock on a Tuesday. Because we've been needing to send cytosine, they will sometimes do a virtual GC visit to get the cytosine ordered and get the family to a lab, which can happen after 5 if the lab is still open. And it's one of the ones in our network, and we do cytosine in-house at Nationwide. So we can get it back like the next day and the next morning. So then if it is elevated, then the family has already talked with the GC about, okay, we need to do this test, and depending on those results, we may need to see you urgently. And then geneticist and I and Hema will see them the next, basically the next day as soon as we know what the cytosine is. So hopefully things will be changing. Ohio will have cytosine in place, and so we can eliminate that initial 24-hour waiting period to get the cytosine done clinically. And so then I think it will be GC calling family and then getting them in for genetics neurology transplant clinic appointment with plan for admission from the clinic appointment. At least that's what we did with our last one, and it worked very well. But it so much has to do with the family. And I think as we talk about what's best practice, we all agree on what the best practice is, but that does not include the family who has no idea this is coming, telling us what the best practice is. Their cell phone has to be on, the bill has to be paid, the voicemail box has to have room in it to receive a message. No one's going to send a text message saying, hey, call me back. You have this, you might have Krabbe disease. And Sharon was just telling me that a lot of 20-somethings now don't ever answer their phone. And maybe that's an interesting thing to think about of how to communicate this stuff by text message, which I wouldn't recommend, but if that's the only way they're going to get communication, I don't know.
Yeah, it's a great point about difficulty perhaps reaching families at times, and a great plug for why psychosine needs to be part of that initial information. I feel when I'm looking at all this, I'm completely stuck until I know what the psychosine is. In the past, New York State, it had been like a day later that would come back. Now it comes back all at the same time, which makes it a lot easier. Dr. Kurzberg.
So I was going to say a few things. He I think said some really important things. One is stay local. Okay. Now I'm saying it as a referral center, right? But it is so much better for the family to stay local. If you have pediatric transplant center within their reach, it's better financially, it's better psychosocially. They have more support around them, and you can move much more quickly than referring to a third tertiary care center or wherever. And I know some people disagree with me on this, but having taken this journey more times than I can tell you, it's just getting harder and harder to get families out of state from the insurance point of view, third-party payer point of view. And it's not as good for the family because they don't have their normal support system. And this is a very hard thing to go through. And I just really think the family should stay local whenever possible. Secondly, I think you said admit the baby because you can't do the work about patient. Even if you could do the work about patient, it's more piecemeal. And when you admit the baby, you can get stuff done in 2.5 days. You know, the MRI, the nerve conduction, the EEG, spinal tap, all these things that are just, at least in my hospital, much easier to organize inpatient. You also, from the payer point of view, it's easier just to be inpatient and be getting it done, not worrying about pre-authorizing everything you need to do. So I want to, you were said them as you were talking, but I really want to point out those things because in general, I think it makes a big difference. The other thing I want to say is that, you know, we live in the world of the internet and people can access anybody anytime, but I really think we have to harmonize our messaging. If a family talks to your group in Ohio and then they email me, which many times they do, and I don't want to say something that you didn't say, and sometimes I can innocently, I mean, I'm not even saying something different than you, but I may say it in different language, and for people aren't used to walking in, you know, in this disease, they think I'm saying something different, and that's not good for anybody. I really think we as a care group need to harmonize our messages so that we don't confuse families in the middle of having to make a really difficult and time-sensitive decision.
Our hospital, what we can and what we cannot offer. Like we don't have gene therapy, or if there's anything additional that can be offered, we always tell them we don't have this, but if this is something you want to pursue, you know, these are the outcomes with this therapy, and we would like you to go, you know, we would say, we would make you talk with the people at Duke, and if that's something you want to pursue. So we tell them that this is so hard and this is so stressful, we would recommend that you stay here so we could get everything done fast. So I agree with Joanne. This is not just for this disease, but for every disease. I do not believe in socially uprooting families for something that can be done at every tertiary transplant center. But definitely we don't have gene therapy. And, you know, with our current family, we're actively discussing, is this, we would like you to pursue it if this seems possible for you, but we don't have it, but we are willing to work with other centers to get this to you. So that's what our approach has
Thank
been.
you.
That for gene therapy, you have to have it, there's only one company, Forge, that has an open gene therapy protocol. Thank you, Forge. That's great. But you have to have a transplant first. And their protocol allows you to be transplanted wherever and then come for gene therapy. So you don't have to, that doesn't have to be part of the initial logistics.
Great, thank you. So I have a couple other comments, and let's move on to the next questions. One comment is that second question there, and we've sort of touched on this. It's really important to communicate quickly with the primary care office. When I get any referral, whether it be concerning for infantile or more likely carrier, my first immediate call is to the primary care doctor's office. And my message to them is, I got the referral, I'm going to be taking care of this. So that way we don't hear about what Dr. Burton was talking about a moment ago, with a family being told by individuals who don't know how to follow up that information. I do that every time, and I would say I have about a 30% rate of catching the family before the pediatrician's office actually called them. I don't know if that's because it's going in first to them or not, but it's really tough. But that is really, really important to try to make sure that you are the one who is in charge of that communication. And then the last thing I'll say, and I'm not going to spend any time on this, but the communications with families who have a baby that looks unaffected, and we get a lot of those referrals in New York State, and making sure that in that initial conversation, you're very clear about that risk, that you're not leaving a family out there for 24 or 48 hours without understanding that. So after introducing myself, if it's a family I've never spoken to before, after introducing myself and that I'm calling about a newborn screen, my next statement is, the first thing I'm going to say is that this does not look like it's going to be a concern for your child or a condition they have, but we have to follow up this result before I even talk about any of the results or the condition or anything like that. So I just lead with that after introducing why I'm calling. So next steps. I actually, although I completely agree with what everybody said here, we actually got all these tests as an outpatient, and we're able to do it. It worked, but admitting definitely makes sense. So I brought the family in next morning, 10:30 a.m., which is what we have to be doing every time, bringing them in the very next day. And then actually at 5 p.m. on Tuesday, I sent messages out to imaging, sedation, neuromuscular, audiology / neurophys, and the person who does the LPs for us, as well as our transplant team. I send messages out to all those people on Tuesday afternoon, just giving them a heads up and letting them know for those who are going to need to help arrange testing, that we needed this testing. I use, for people not as familiar with the condition, I use a lot of life or death terminologies, just this is with the medical providers, just so they understand the urgency, because a lot of people contact them about urgent things that might be slightly less urgent than this. So all of those messages went out back on Tuesday. Now we're Wednesday morning, 10:30 a.m., day of life 9. And the first question there, which is, how can you prepare your center for emergent need for testing? I'm not going to spend much time on, but I'll just mention that when a center is a referral center for Krabbe, it's very important that all of these individuals that I put up there, that I contacted, understand that this is a thing, infantile Krabbe, and that your center follows it up, and you have need, rarely, very rarely, hopefully, for this kind of urgent testing. Putting together a protocol and then sending that protocol out really helps. And then setting up at least one initial meeting with these individuals, just so that way it's in their consciousness that this kind of thing can happen. And when you need them, you really need them. We haven't done this next step yet, but I think it'd actually be quite a good idea, because, you know, we heard you can go 2, 3 or more years without getting an infantile case in any given state. So having at least an annual brief meeting with this team just to kind of keep them in the loop. Maybe new people have come on, et cetera. So keeping everybody in the loop is really, really important. And then the other way to get this done is that you have to be very persistent. So I emailed/paged our sedation team member 3 times within the course of like, a few hours because they weren't getting back to me because they were rounding in the PICU and they were busy, but I just needed them to know that I had to speak with them right now. And it worked. So you just have to be really, really persistent. But I want to move to question 2 here, which is really, really important. And we focused a little bit about this, what Dr. Kurtzberg was just mentioning, but now we're in the office and we're sort of having the larger conversation about the condition and the potential benefits and risks for transplants. So I was going to go to our panel and hear about how strategies for having that conversation for a patient who you're thinking the tests aren't back yet, but you're thinking this is most likely infantile disease. What goes into that conversation about the condition and risks and benefits of transplant? Yeah, either. Yep.
I'm retarded. Looking at the microphone. So I think ideally you need to have the right people in the room to talk to the family or the person in the room who's at least knowledgeable about the natural history of the disease without treatment, the treatment options available, and the impact of accessing those treatment options. So when I talk to the family, I mean, I've done this forever, right? And I know the answers to all those questions. And I usually start with, what do you know right now before I say a word? Because most families have actually Googled or talked to people or whatever. And I just want to know where they're starting from before I put my foot in my mouth. So I actually start with, what have you heard? What do you know? I'll say, did you look up anything about Krabbe? Things like that, just to bring out where they're starting. Then I will definitively say, if it's in this kind of case, the cytosine's 15, I say your baby has infantile Krabbe disease. And I explain what that is. And I explain briefly what the natural history is without treatment. I then explain what treatment options are available, which in this case is really transplant and or supportive care, palliative care, et cetera, and what those 2 things mean. And then for transplant, when I was younger, I used to go through every day and every chemo and every this and every that. I don't do that anymore. I do use the word chemo, but I focus on timeframes and impact and risk and benefit. So I talk about going to a transplant center, about being in the hospital for a couple of months, about the different lines and things that will happen, the risks of transplant that have nothing to do with Krabbe. And I stop many points along the way to ask if they have questions, and I read the room, so to speak. And then I give a little bit about long-term outcomes and how they are definitely not perfect. And I kind of divide it into 3 buckets of kids who are sort of pretty much okay, which is about 10%. And then the kids in the middle who have some impairment, but are having what their families perceive as a good quality of life. And I describe what that looks like. And then the lower 10% where there are very, very impaired kids, where their lifespan is shortened and their function decreases over time. I explain about the peripheral neuropathy. When I'm talking about therapy now, I do mention gene therapy, but I am very careful to say it's in early phase testing. There are only a few slots. We don't know yet if it's safe or not, and we don't know if it helps the disease or not, but that it does help in animal preclinical studies, and that's why it's now in the clinic. I know I'm saying a lot, but that's kind of the conversation I have with the family.
Thank you.
Yeah, I agree with that. And I think an important thing is to do it in pieces. You know, Joanne was alluding to that, I think, and that's one of the benefits of having a patient inpatient. Of course, you can have multiple conversations, but we know when you give a family bad news or you tell them something awful, they glaze over and then they don't hear anything more that you've said. You know, the fine details of risks and benefits, that's really out the window. So, you know, first they have to process that this baby probably has a bad, potentially lethal disease. That's it. That's all they're going to hear. And then you go back and you start adding more to it, and you have a little time because you're doing these tests and so forth. And, you know, you have the child in hand. So I think that's really important. It's really important that you have psychosocial backup, social workers, you know, other players who can help the family and pick up the pieces when you walk out of the room, and also help them with logistical issues because they're overwhelmed with, I got to, you know, how am I going to do this? How do I even have the baby in the hospital? I got 3 other kids at home and all of that. So there's so many issues, you know, so it's really important to do that. And still we encounter issues because, you know, we have families who are mistrustful of the healthcare system, and you tell them that their baby has this thing they never heard of and they don't see anything. Baby looks fine. They don't believe it. You know, they want to get second opinions, go somewhere else, this and that. And all of that's fine, but it better be fast, you know? And so there are, you know, there are tough times sometimes, you know, when you encounter that sort of situation. But I think just being persistent and going back and understanding and, you know, having a genetic counselor who's got those skills of, you know, counseling and dealing with this, your social workers really helps.
Yeah, absolutely. I just wanted to highlight that we often think about and talk about the families that we're trying to help in some ways. There's no way to do this, but slightly soften like that initial conversation, especially over the phone or in person. But there are going to be other families that are not, that might be mistrustful of the medical system, or just in general are not understanding risk, and might be more prone to, like, if you say we need to see this patient, you know, see your child tomorrow at 10:30, might say, well, next Friday works better for me, that kind of thing. So one key component to that is indicating your concern. Okay, maybe it doesn't need to be done with some families, but I am concerned about this, or I'm very concerned about this. Those are really important statements to make sure that families understand the gravity of the situation. They're not making decisions like putting off a certain appointment or whatever without that information. Yes.
Is there a mechanism to help the families with the costs associated with everything they have to do, not just the medical costs, which I'm assuming are just astronomical, but like the living costs that, you know, if they have to literally move somewhere for a certain amount of time and all of that. Is there someone who can help them with all of this?
Yes.
So yeah, I'm sorry. It's okay if I talk?
Yes, absolutely.
You know, most pediatric transplant centers have, first of all, social workers and programs in place to help families with lodging or food or whatever they need to stay in the area. I know I've reached out to Hunter's Hope sometimes when family has to fly somewhere, and they've helped us get a flight for the family. But in general, it's part of the pediatric transplant culture to recognize that these families have needs outside of the direct medical care, which should be covered by whatever their payer is. That's, you have to get the approvals up in advance, but once you have that, the medical care should be covered. But like you say, lodging, food, gas money. In our shop, we have a family support program. We have a Ronald McDonald House with transplant suites. Every program is a little bit different, but I would say it's part of the phenotype of a pediatric transplant center to provide that kind of support.
I totally agree with the kids that are getting transplanted. They have a
Right.
really intense, robust support system. I worry about the families who choose not to transplant. I think there's less available. I think our social workers try to help our clinic, but I think some of the family support services are less able or less interested in providing support for families who, for whatever reason, choose not to transplant. And we've had families have significant psychosocial and financial hardships caring for a kid even a year or two of their life that were untreated.
Thank you. I'm going to move on to the next slide. I just wanted to make a quick point about this communication. I think that two things I always think about when I'm having this conversation is one, you need to be very organized. And being organized is something that with this very difficult conversation and the family's brain sort of swimming, to say the least, that kind of organizational structure for how you approach this conversation is really important. And then almost like opposite of that in some ways, I guess, is that you also have to take your lead from the family in the discussion and understand from the beginning of the discussion where they're going and make sure that you're not tied to the things that you usually say in the way that you usually say them, but make sure that you're taking the family's lead in that discussion as well. And those are just really, really important points in having this conversation. So moving ahead here, so this is next day, Thursday, 3 p.m., which is now day of like 12, or 10, sorry. We had the conversation the previous day. The family agreed that they wanted to move forward with transplant. Unfortunately, I agree with what Dr. Kurtzberg said. I wish we could have done the transplant, but in this case, the family opted to transfer out of state center because of the experience. It's a hard nut to crack when there's a place that has a lot of experience in this particular disease transplant. So that's what this family elected to do. But you could see all the tests that were done there, and all of those were completed within 48 hours. This is outpatient. Within 48 hours of that referral coming in. So one thing I really want to make everybody help everybody understand is that this is possible to do. And it's possible to take that 30-day goal and to really strive for that. So you can see all that testing. We also made an appointment with our local transplant team for the initial HLA typing, which I didn't understand until this patient is really, really important to do as quickly as you can. In this case, we did buccal high res, which had a very high turnaround time for us. You could see there, I'm not going to go through all the details of the case, but basically on the MRI scan and the nerve conductions, you can see that there was evidence of demyelinating disease consistent with what we consider as most likely, which was infantile Krabbe. And then we sent cycosine in red blood cells to Mayo and got back a result that was consistent with infantile Krabbe. So within 48 hours, we had a pretty good confirmation that this, in fact, was infantile Krabbe and that we needed to move forward. And we probably don't have quite enough time for this first question, but it's a really important question. So we'll see if anybody has any brief comments on this. But you know, a big part of this process, practically speaking, is now getting insurance authorization. I didn't have any problem getting authorization for the tests. That didn't hold anything up, but getting authorization for transplant, number one, and number two, in this case, an out-of-state referral. Okay, those are two things that need insurance authorization. We know that that process is not very quick. So I can kind of let you know how our process went, but anybody with any major pearls of wisdom about how to navigate the insurance authorization process urgently for these patients?
I would think part of my job as care coordinator is getting authorization for a lot of these processes. And it always comes down to
getting in touch with the medical director for a peer-to-peer, right? So by knowing who those medical directors are and going to them in the very beginning, you can bypass already that denial, go right for the peer-to-peer, and probably get it done within 24 hours after that peer-to-peer is set up. That would be my thought.
Before submitting the authorization, even finding out who the medical director is going to be.
Exactly,
Gotcha.
exactly, who those medical directors are
Mhm.
and get a directory made up, right? For the
The
go-to
different
person.
insurance companies. Yeah, great point.
So I was going to say, talk to a human, same thing.
Yeah,
Yeah.
I would agree with the same thing. At our center, we have a whole team that just does this. So the insurance authorization, and they have a point person at each place that they have established a relationship with already. So they know that a kid with Krabbe is coming in, then they already have a point person to get insurance authorization. And I think I will echo that, having a central team with each one identified, who knows their role and who builds over time a relationship with all the necessary parties. I think it's very important. In the beginning is hard, but afterwards, if you have a team that knows and has the relationships, it moves much quicker. And then the patient also gets the same message from different people in the same team, like Dr. Kratzberg said. It's not just between centers, but inside the center itself, when a patient sees all of these different people getting all these different tests, it's important that they hear the same thing. Because if they hear one thing in my clinic, and then they're getting something else from the EEG tech or the MRI tech, they're going to interpret that very differently. So it's important to educate inside your team so that you have a unified message.
Absolutely. So that kind of initial organization is really important. And I'll add, while we're waiting for Dr. Orchard to speak, that we have a letter that it sends out to insurance that is obviously, it's true, very heavy-handed about the situation and the risk to this baby. So not kind of sitting down to write that letter after you get the patient, but having that kind of thing ready, so that way you can kind of send it out. And in sending that letter right with the initial prior auth, and making it a rush, obviously, as much as we can prior auth, I was able to get connected with a physician at the insurance company within 24 hours, I would say, for that peer-to-peer, which is absolutely critical piece, is getting to talk to somebody and to explain. So that kind of organization is really important. Dr. Orchard.
Yeah, I was just gonna say, so the centers here, the transplant centers that are talking have gone through this process, so they've worked out the bugs of this. But our transplant finance office has a standard way of going through referrals, and it takes forever. And so you have to bypass that thing totally. And it's better to talk to people up front when you start doing newborn screening, so people realize that in these situations, you can't go through the standard process because that could take months. And getting approval from Medicaid is different than getting approval from Blue Cross Blue Shield or some private provider. And cross state is different than doing it in state. So there's all these variables that it would behoove groups that are thinking about doing this to have all these conversations before it happens. Because otherwise it's really difficult to get things put together.
Absolutely. So having kind of that, that planning is really important in the conversations. I'll say that, I mean, I guess I got lucky perhaps, but the person I got to talk to really understood the gravity of the situation. I mean, these are people, so hopefully they'll understand the gravity of the situation. And this individual actually gave me their cell phone number. So that way we can kind of stay in contact as they were trying to help push through this approval on their end through the insurance company, and sort of texted back and forth a few times over the next day or two to get the information they needed and to make sure that they were communicating with me about, where they were in the process. So that was really great. we're pretty much out of time. Suppose since I force others to stay on time with their talks, I should probably do the same. So I'm just gonna kind of show this quickly. So we did get insurance approval. We actually didn't get the transplant, but we got the out-of-state transfer and the initial transplant evaluation, which was like the step that we could get approved at that time. That was by Friday, so that's so 3 days or so after the initial referral came in. And then, as Dr. Kurtzberg said, this was very important. She really didn't communicate with family until we got that insurance authorization for out-of-state transfer, because that's her point about making sure that everybody's on the same page. And if she accidentally said something that was different from what our team was saying, that would erode trust in our team, which would be devastating. So once we got that, Dr. Kurtzberg then connected remotely with this patient to help set up plans for transfer. By Monday, day of life 14, the family traveled down to that transplant center after having all the initial workup, including the HLA typing already done with us. And then we got that typing back on Tuesday, so 1 week from the referral, we're able to get the patient in, have all the conversations, get all the testing done, get the HLA typing completed and back, all the insurance authorizations for the transfer, and the patient down to a transplant center. So it was all within 1 week. So this is possible. It's hard, but it is most certainly possible. And we don't have all the updates yet about this baby, but I will say that they did receive transplant by day 30 of life. So we're able to meet that goal. And we'll take maybe one more question, one or two more comments, but I'll just highlight that a talk, I think this afternoon, is going to take from here about how a center can help prepare themselves to be a transplant center and what kind of things need to be in place. Yes.
Just for the HLA typing, and different centers may do this differently. We usually call the lab director of the HLA typing lab and tell them this is really urgent, because sometimes our turnover is 7 to 10 days. We will tell them, can you bump this up and give us a result as quickly as possible so we can choose our cord blood. So that's something we do as soon as we know the baby is coming in. The other thing we have learned over time is we can do buccal swab or lab draws, blood draw for HLA typing. Sometimes we don't get the result from the newborn that quickly, so we just go straight to blood draw for HLA typing as soon as we have the first contact with the baby. So this is just something we do at our center. We call the lab director immediately.
Yeah, absolutely. So the comment was calling the lab for HLA typing, making sure that they know that this is urgent. I think that you could back up that idea and make it more general. That's part of what we need to do every step of the way, is to contact whoever needs to be called to make sure they understand the urgency. And that's true in many steps. And for this patient, our team, local team for our hematology oncology team most certainly did that. And we had that conversation about buccal versus IV, and the lab was very certain they could get it back. And they did on the buccal specimen, but understanding those details is really, really important. All right, I think we're out of time. Thanks so much for Dr. Kurtzberg and Dr.
can I
Burton,
just
and
make
for everybody.
One quick
Oh,
One
sorry.
quick comment.
Is that
For families that are either remote or need to go to a transplant center that is familiar with metabolic disorder transplants or so on, does this association have like a directory? So if they connect and they have families in some place, then maybe they would choose to go to a place where they have, if they have to travel outside of their native region, then maybe it would be useful to tell them what all the places are that are familiar with these transplants, and they can pick a place where they have family support, because I fully agree, it's really hard for families to move. And they may have someone in Nashville, but not in California, something like that.
Sure.
May make it easier.
That makes sense, the options. Thank you. And actually, before I close, let me just turn it back over to our panelists, see if there was any last points that anybody wanted to make.
No, not for me.
I think we're going to discuss more as time goes by. So I won't say anything now.
All right, thanks so much. And thanks for your discussion.